We move on to the next talk on the role of progesterone in preterm labor. And to give us more insights to it, we have Thejavathy Madam. She is currently the consultant and HOD of OBG department at Bhagwan Mahavir Jain Hospital. Okay, thank you.
A very good afternoon to all of you. And at the outset, I would like to thank Dr. Kamini and her entire team for this opportunity, and also congratulate for such an excellent academic conference. Now, my topic is role of progesterone. What does the updated evidence say? I think all of you will agree that progesterone is one of the most abused drug in obstetrics, prescribed by all categories of doctors, be it Ayurvedic doctor, homeopath, general practitioners, gynecologist. They use it left and right, whether it is indicated or not. So, with such a thing, I think it's better to have a proper indication. Let's go through the studies and see what the recommendations, what the studies, whether to use progesterone and in what situations. Just to refresh your knowledge, progesterone is a key hormone secreted by corpus luteum initially and then by the placenta till term to maintain pregnancy. It has got an important role in preparing the endometrium for implantation and also maintaining maternal-fetal connection. Bleeding in early pregnancy can be due to an abnormal embryo, or it could be due to insufficient progesterone secretion, which maintains the embryo uterus connection. This can also be the consequence of an abnormal pregnancy, which is not able to produce sufficient progesterone secretion. Whether it is a cause or a consequence, inadequate progesterone is the salient feature in early pregnancy bleeding. Progesterone supplementation in the setting of bleeding may be beneficial for its uterine relaxing and immunomodulating effects. So, with this background, let us see where all the progesterones are used. In day-to-day practice, I think most of us use progesterone in threatened miscarriages, recurrent pregnancy loss, preterm labor, and luteal phase defects and ART. Now, coming to threatened miscarriage, according to the RCT published in Journal of Reproductive Infertility 2014, progesterone suppositories did reduce the rate of miscarriage in women treated with progesterone, but of course it was a small sample and it was not statistically meaningful. The next was the Cochrane Systematic Review, which was published in August 2018. It included 7 trials, and the review suggested that progestogens are probably effective in the treatment of threatened miscarriage, but have little or no effect in the rate of preterm birth. This is the latest article, which is published in New England Journal of Medicine, May 2019. This is, of course, one of the largest RCT studies, double-blinded, placebo-controlled, where a good number of participants were tried. The progesterone was started as soon as the patient had bleeding and was continued till 16 weeks. It was given in the dose of 400 mg BD, and then the live birth rates were studied. It was seen that there was no difference in the group treated with progesterone or the placebo. So it was concluded that progesterone was not effective in treatment of threatened miscarriage. What does the ACOG has to say? It said that for threatened early pregnancy loss, the use of progestins is controversial and conclusive evidence supporting their use is lacking. But however, it added that in women with at least 3 or more recurrent pregnancy loss, they do benefit with treatment with progesterone. Coming to recurrent pregnancy loss, the Cochrane Database Systematic Review 2013 had 4 trials, and it showed a statistically significant decrease in the miscarriage compared to placebo or no treatment, but then it was of poor quality and there was no significant decrease in the rates of preterm birth. The next is the systematic review, a meta-analysis of RCT, which was published in Fertility Sterility Journal 2017, and which provided evidence that supplementation with progestrogens may reduce the incidence of recurrent miscarriages and seem to be safe for the fetuses. One of the big trial, which was PROMISE trial, again the same study, actually this RCT was a large multicentric RCT with double-blinded placebo, where the primary outcome studies was live birth rate and the secondary outcomes were the rate of miscarriages, the neonatal outcome, and the adverse outcome on the mother. So 836 women were randomized, 404 were given progesterone and 432 with placebo, and live birth rate was not really different in these two groups. So it was concluded that progesterone therapy in the first trimester did not result in significant increase in the rate of live births. Of course, this had a limitation that progesterone was started after the pregnancy test was positive and not in the luteal phase defects, because there was a thought that maybe if the progesterones were started in the luteal phase, there could have been a significant difference in the live birth rates. And here the progesterones were given only till 12 weeks, unlike in threatened miscarriages or the next PRISM trial, where the progesterones were given till 16 weeks. This is another trial, a big number, 2079 were treated with progestrogens and 274 with placebo in patients who had started bleeding, and they were given till 16 weeks. This was published in New England Journal of Medicine in the month of May 2019. These were the key findings. The live birth rates were similar in both the groups, whether treated with progesterone or placebo. Even the miscarriage rates were almost comparable. The only difference which made was in the group who had 3 or more recurrent miscarriages, where the live birth rate was 15% higher than in the placebo group, which did conclude that it was beneficial in the patients with 3 or more recurrent miscarriages. Now coming to preterm labor, lot of papers have been published against, in the recommending vaginal or oral progesterone in prevention of preterm labor. This was an Indian study which was done in March 2017. Oral versus vaginal was compared. It was shown that the term births were higher in vaginal progesterone, which was around 73.3 when compared to oral, which was around 60%, and concluded that progesterones were safe and effective in reducing the risk of preterm births and as well as in reducing NICU admissions. This was another important study, optimum study, where vaginal progesterones were started when the scan picked up short cervix, and then it was continued till 34 weeks, and the progesterone was given the dose of 200 mg, and the conclusion was it did reduce the risk of preterm birth and the neonatal morbidity and mortality without any deleterious effect on the neurodevelopmental outcome of the fetus. And it did recommend universal transvaginal cervical length screening at 18 to 24 weeks so that short cervix could be picked up and these patients could be offered vaginal progesterone. Another meta-analysis of individual patient data, which was published in American Journal of Obstetrics and Gynecology, February 2018, where 498 were given vaginal progesterone and 476 placebo. in women with short cervix, and here also they found decrease in the risk of preterm birth and improved perinatal outcome. This was an article in December 2018 in Medscape, where both hydroxyprogesterone, parenteral administration of hydroxyprogesterone caprate was advocated in patients with recurrent preterm births, and vaginal progesterone in patients with the preterm contractions and short cervix. A few studies comparing the progesterone versus cervical cerclage. This was a systematic review which was published way back in 2013, which showed that vaginal progesterone equally effective as cervical cerclage in preventing preterm births. Another article showing adjuvant progesterones given to patients with cervical cerclage, which showed a reduction in spontaneous preterm births, low birth weight, and neonatal ICU admission. This was in 2016. This was an Indian experience where 25 cases with cervical and cerclage and 25 with vaginal progesterone. This was oral progesterone, and it was concluded that natural micronized progesterone is as effective as cervical cerclage. And since this is a non-invasive, easy to administer and compliant with the patients, this was recommended, and it had an edge over the cervical cerclage. Coming to role of progesterone in patients with specific conditions, that is, all of us know that risk of preterm births are increased in IVF and ICSI pregnancies and also in twin gestations. 1 or 2 study showing use of vaginal natural progesterone, which reduced the rate of preterm births in singleton IVF and ICSI pregnancies. This is another article published in Ultrasound Obstetrics Gynecology 2017. This was in twin gestation meta-analysis, which concluded that it was effective in twin gestation where short cervix was picked up, of course, in cervix less than 15 millimeter, which was published in 2017. This is a article which came up in Perinatology Update 2018, where the routes of administration were assessed, and though the parenteral injectable 17-hydroxyprogesterone was useful in reducing the preterm births, but there has been shift from parenteral to the oral and the vaginal progesterone, which is more acceptable to our kind of population, and more so oral is accepted. Many of them are really not comfortable using vaginal preparations. What does Foxy has to say regarding the use of progesterone? Foxy also recommends progesterone use, and there has been the different routes of administrations have been tried, and it is of that opinion that oral natural micronized progesterone formulations have a better compliance, but more Indian studies are needed. These are the 5 studies done in 2018 meta-analysis. All of them favor progesterone to prevent preterm birth. This is the guidelines all across the globe, right from Western Australia, European Association of Perinatal Medicine, France, NICE guidelines, FIGO, ACOG, and Canadian. Almost all of them recommend use of vaginal progesterone in the dose somewhere between 90 to 200 mg, and starting from 18 to 22 weeks when a short cervix is picked up on scan, and also in the patients with previous history of preterm birth, and it is given up to 34 weeks. Some of them even recommend up till 36 weeks. And NICE guidelines has been updated in this August 2019, which recommends 200 mg of vaginal progesterone daily from 18 to 22 weeks up to 34 weeks. One RCT against for hydroxyprogesterone caprate, a multicentric RCT, which has shown to decrease the incidence of preterm births and also lower incidence of IVH, NEC and need for supplemental oxygen. But all of us should be very clear, injectable hydroxyprogesterone caprate should be used only in patients with previous history of preterm births, whereas progesterone in both situations where previous history of preterm birth and also in patients where the short cervix has been picked up on scan. This is of course different preparations showing different side effects and efficacy. So depending on the population, we can use formulations like vaginal, oral or injectable. As far as safety is concerned, natural micronized progesterone is proved to be safe. And a little about the formulations. Studies have been done and it has been found that the progesterone sustained release are definitely better compared to immediate release because of reduced side effects, once dose convenience and improved bioavailability. Now coming to the last situation where we use progesterone in LPD and ART, there have been articles published in endocrinological gynecological endocrinology and Journal of Ovarian Research, but everyone agrees that progesterone used in ARTs increase the pregnancy success rate, improving the pregnancy outcome. When it has to be started, of course all of you know, I don't have to tell, on the day or a day after pickup of oocyte. And according to the Cochrane database, they say pregnancy rates are better when progesterone supplementation is started on the day of pickup or the day after pickup. Now coming to the committee opinion which has been published in ASRM, what is the role of progesterone and its use in LPD and ART. It says currently there is no evidence that progesterone is beneficial in natural unstimulated cycles. It is definitely indicated in ART treated pregnancies in GnRH agonist or antagonist stimulation cycles, and IM and vaginal are preferred than the oral, which gives better tissue concentration and endometrial levels, and pregnancy rates are better in oral in vaginal and parenteral administration when compared to oral, and progesterone has to be supplemented only up till 8 to 10 weeks. So my take home message is progesterone is essential for pregnancy initiation and maintenance. Different progesterone preparations exist, allowing alternative choices for each case. Guidelines across globe support progesterone treatment for prevention of preterm labor and associated adverse perinatal outcome. Micronized progesterone is a better option over 17-alpha hydroxyprogesterone caprate in terms of safety profile. And in the management of threatened miscarriage, progesterone has no role, while it is proven beneficial in the management of recurrent miscarriages. Thank you.
Thank you very much, madam, for such an elaborate discussion.